You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for November 15th, 2019. This week, anticoagulation interruption for surgery, marijuana, an ORBITA substudy, ISCHEMIA trial baseline characteristics, and a bit more AHA preview. First off, I want to apologize for my voice. I have a killer virus that's attacked my vocal cords. First topic is the increased use of DOACs have changed decision-making about the interruption of oral anticoagulation at the time of surgery. In the days of warfarin, we had to stop warfarin many days before, and if the patient was high risk, bridge with heparin. Now, warfarin is tricky because of its inconsistent and variable pharmacokinetics. DOACs have a much more predictable pharmacokinetics, and the idea is that you could stop the drugs 1 or 2 days before and minimize the time of being unprotected. JAMA Internal Medicine recently published a large cohort study that came from multiple centers, but it was led by the McMaster's group, and they investigated the safety of a standardized perioperative DOAC management strategy. Their acronym is called PAUSE, P-A-U-S-E, and the study enrolled greater than 3,000 patients who were scheduled for surgery from centers in the U.S., Canada, and Europe. DOAC regimens were omitted for 1 day before a low bleeding risk procedure and 2 days before a high bleeding risk procedure. The DOAC regimens were resumed 1 day after the low risk bleeding procedure and 2 to 3 days after the high bleeding risk procedure. They had 3 cohorts, apixaban, dabigatran, and rivaroxaban, and about a third of the patients in this study were considered high bleeding risk surgery. 30-day major bleeding rates were low in each cohort, 1.3% for apixaban, 0.9% for dabi, and 1.8% for rivaroxaban. Arterial thromboembolism rates were also low, 0.2% for apixaban, 0.6% for dabi, and 0.4% for rivaroxaban. They found that preoperative DOAC treatment levels were measured in 2,500 patients, about 84%, and most of these patients had very low levels of the drug. The authors write that it's hard to compare rates in these studies to previous studies because management in previous studies was not standardized, and previous studies included fewer high-risk patients. For instance, in the BRIDGE trial, patients who were not bridged had a 30-day postoperative rate of major bleeding of 1.3% and thromboembolism rate of 0.4%. And those are similar numbers to what we have in this study. Now, this study is not a randomized study, but I think it helps characterize that if you standardize the DOAC interruption protocol, you achieve low rates of bleeding and arterial thromboembolism. This study leads the podcast because it highlights one of the most important issues in all of medicine, one that often seems too basic to repeat, but that is procedures in surgery come with benefits and harms. The risk of interrupting anticoagulation is small, yes, but it's real. And that's why patients should have a true understanding of the benefits and risks of the surgery beforehand. For instance, what happens if the patient doesn't have surgery? If someone has a broken femur, fine, then you have to interrupt oral anticoagulation and fix it. But if someone, say an older person, has competing causes of death and wants a colonoscopy for screening, then that is a different risk calculus. I talk to surgeons often about the value of the surgery relative to risk of oral anticoagulation interruption. In many cases, we come to the conclusion that there are non-surgical approaches that are wise. Next topic is marijuana use. The AHA, American Heart Association, have allowed media coverage of 2 observational studies on marijuana use that will be presented at the meeting this weekend. You have to be careful with marijuana studies as they often get more attention than the rigor of the science deserves. But the 2 abstracts covered nicely by veteran journalist Sue Hughes have some notable signals of potential harm. 2 other background factors make marijuana science worthy. One is that the drug's use is on the rise as states decriminalize the drug. And 2, the potency of marijuana also seems to be rising. Now, one of these studies looked at pooled data from a CDC survey called the Behavioral Risk Surveillance System. They had 43,000 survey participants. About 14% reported marijuana use in the last 30 days. The investigators were interested in the association between young onset stroke and marijuana use, and they found that compared with non-users, recent marijuana users showed an 82% higher risk of stroke with an adjusted odds ratio of 1.82. They also found a dose response curve as the odds ratio increased with frequent use of marijuana. While there are potential plausible mechanisms for this association, the authors and discussant Dr. Bob Harrington noted that this is observational data with self-reported marijuana use and self-reported stroke. That, of course, is a serious limitation because taking the word of a guy who smokes a lot of weed that he had a stroke seems like a very soft adjudication of an endpoint. And good on Sue Hughes for working the limitations of this study in the 5th paragraph of the news column. The second marijuana study involved an analysis of the nationwide inpatient sample over 4 years in which the authors compared about 500,000 people with an arrhythmia diagnosis to 67 million patients without an arrhythmia diagnosis. They then did logistic regression and looked at cannabis use disorder as a variable, and they found that cannabis use was associated with a higher odds of arrhythmia hospitalization in the young population and an even higher rate of arrhythmia hospitalization in the population between 25 and 34 years. This study, too, is full up with limitations, but again, there's a potential signal of harm from marijuana use. And I think the marijuana issue in our society is kind of weird. Yes, I understand that the drug's therapeutic window is huge, and it probably will turn out to help some conditions, and making criminals of marijuana users defines stupid policy. But I am suspicious that this grand experiment without data that is ongoing now in the U.S. won't turn out well from a health standpoint. I hope the federal government decriminalizes marijuana use so that we can conduct proper studies on its safety and potential benefits. The third topic today concerns an ORBITA trial substudy. Now, the ORBITA trial is definitely back in the news, and you recall that ORBITA randomized patients with angina and single vessel coronary disease to either PCI or a placebo procedure. It shocked the world of cardiology by showing that PCI of a severe blockage did not result in a significant increase in exercise time. The trial was powered to find a 30-second improvement, but only found a non-statistically significant difference of about 16 to 20 seconds. The lead author, Dr. Rasha Al-Lami, knew the trial would be criticized, and so she, along with the co-authors, published the coronary angiograms in the appendix of the Lancet, so that all people could see that these were lesions that few operators would walk away from. They then published a substudy looking at whether functional measures of the degree of stenosis, like FFR or IFR, would predict angina relief. And they found no relationship between the degree of stenosis and angina relief. This week, they published another substudy looking at the relationship between the degree of ischemia on dobutamine stress echo and relief of angina. Now recall that the majority of patients in ORBITA had dobutamine stress echo before randomization. This time they found the relationship. Indeed, there was a detectable interaction between pre-randomization stress echo score and the effect of PCI on angina frequency, with a larger placebo-controlled effect in patients with the highest stress echo score. The P for interaction was 0.03. But this was just one patient-reported response variable. The dobutamine stress echo score had no relationship with other important measures of angina. For instance, freedom from angina, no effect. Physical limitation, no effect. Quality of life, no effect. Canadian Society Angina Class, no effect. Treadmill exercise time, the most objective measurement, no effect. Okay, this could be something. You could explain the lack of correlation with FFR by saying that FFR just tells you the amount of stenosis, but it doesn't tell you anything about how much downstream myocardium there is. Dobutamine stress echo, however, gives you a measure of the amount of heart that's ischemic. So big amounts of ischemia may lead to more angina relief, and that makes sense. The authors make a nice explanation of this in the discussion section of the paper. But on the other hand, the P for interaction barely makes significance at 0.03, and why is no other angina variable showing the same interaction? The authors state that 17 of 200 patients in the trial did not have a dobutamine stress echo, and since the original trial showed no significant effect in the main endpoint, there is reduced power to detect variation in subgroups. So one wonders whether this positive correlation is similar to the very famous post hoc analysis of the ISIS-2 study, which showed that astrological sign could correlate to aspirin effects after MI. In other words, is this one positive correlation due to chance? I think the main lessons of ORBITA stand, and that is that there is a huge effect of the doctor-patient interaction in improvement of patients after PCI. Faith healing, feeling good about being fixed, and subtraction anxiety, being uneasy about walking around with a blockage, these concepts remain. And I think they're crucial concepts when we look at the rates of hospitalization in the unblinded arms of the ischemia trial on Saturday. The next topic today is more information on ischemia trial baseline data. This week, ahead of the ischemia trial presentation, some of the trialists published a study in Circulation Outcomes on the baseline predictors of LDL cholesterol and systolic blood pressure goal attainment in this trial. The data included all randomized participants in the ischemia trial with baseline and 1-year LDL and blood pressure measurements by January 28, 2019. The sample included 78% of the nearly 5,200 patients in the trial. And the bottom line is that 94% were on antiplatelets, 95% on statins, 80% beta blocker, 66% on ACE or ARB. The study found that 52% of patients reached their goal LDL, while 75% of patients reached their goal systolic blood pressure. This was discussed on Twitter, and as Venk Murthy and Bobak Zianon have noted on Twitter, trial participants had access to a wide array of free medications and medical care, and yet many did not reach goal. And I think this speaks to the challenges of reaching goal in the real world. The real world is where patients have nowhere near the healthcare access of patients enrolled in this $100 million trial. That said, I think that number one, treatment goals are a bit overrated. As of just a few years ago, the LDL goals were abandoned. Now, I know they're back in, probably because of extremely modest reductions in non-fatal cardiovascular events in the PCSK9 trials. But same with blood pressure goals. It's not like we actually know the best systolic blood pressure or that the best systolic blood pressure is written in stone. I mean, the SPRINT trial interpretation is hardly universally agreed on. Also, if medical therapy was super stellar, people would say the trial is not reflective of real-world practice. And if the hard endpoints in ischemia are not reduced, the spin would be that the control arm was too good, like in the PREVAIL trial of Watchman versus warfarin. I think the medical therapy arm in the ischemia trial looks quite reasonable and pretty typical of what we see every day. So I don't think the medical therapy intensity will change interpretation of the ischemia trial results. In fact, if you can count MIs, CV death, overall death, and cardiac arrest in the two groups, you can pretty much understand the ischemia trial. Last topic today, and my voice is barely hanging in there. There are other topics at the AHA meeting, and just a few brief notes on these. Professor John McMurray from Scotland will present sub-studies on two recent mega trials. First is his report on non-diabetic patients in the DAPA-HF trial. Recall that DAPA-HF found that dapagliflozin, compared with placebo, reduced the rate of worsening heart failure or CV death by a statistically significant 4.9% in absolute terms. That is a big effect. And crucially, more than half of the enrolled patients did not have diabetes, and in the subgroup analysis, the reduction of the primary endpoint was similar regardless of diabetes status. Now, McMurray and colleague Scott Solomon from the Brigham will present two sub-studies of the Paragon-HF trial. These will be trickier to interpret because in Paragon, sacubitril valsartan compared with valsartan alone did not result in a statistically significant reduction in hospitalizations or CV death in patients with heart failure and a preserved ejection fraction. The two sub-studies will address subgroups that look to have a benefit in the main trial with sacubitril valsartan combo, and that is women and patients with a mid-range EF. Also at AHA, the inflammation theme gets another test with colchicine in the COLCOT trial. This is a placebo-controlled trial that included more than 4,700 post-MI patients. At AHA, the investigators will tell us whether colchicine, 0.5 milligrams daily, reduced the composite endpoint of major cardiac adverse events. A Korean investigator group will present a trial on early surgical intervention in patients with severe but asymptomatic aortic stenosis. This is a really important study because with the advent of TAVR, there is more of a temptation to operate early in the course of AS. To date, we wait for symptoms, but this has always bothered me because aortic stenosis can be a deadly disease. We definitely need more data in this group of patients with severe but asymptomatic AS. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. I'm sorry about my voice. Remember, if you like this podcast, please consider giving us a review, a rating, or subscribing to us on whatever podcast app you like. Thank you, and we'll see you in Philadelphia.
You're listening to This Week in Cardiology from theheart.org on Medscape.